We're delighted that we've been able to collar Dr. John Bright to be with us today, who's an experienced respiratory physician based here at the Manchester Royal Infirmary, who's got a passion for high quality care. He's got a specialist interest in bedside ultrasound scanning and also VTE. He's got a proven educational background, holding position previously of Associate Dean of Medical Education. He's a renowned speaker at a variety of educational forums and conferences nationally and internationally. So very honoured to have him with us here today. So I'll hand over to you, John, and we'll hold questions for the end, if that's okay. If anyone's got any questions throughout the day, you can either post them on the Q&A or on the chat. And I'll pose them to you at the end.
Brilliant, thank you very much. I just can check, can everyone hear me? Any problems with the audio? Fantastic. Now, I've just got a picture in front of you. If you're interested, this is why I'm interested in blood clots. This is a patient of mine from a couple of years ago. And you can see the heart, and above the heart, what you think is an unfolded aorta is actually clot deep inside the pulmonary arteries, huge things. And I've got an interest in thrombolysis. And the normal talk I would always give is PE and thrombolysis. Things have changed. COVID's around. Okay, so you can see in front of you the slide, and COVID and PE, I'm confused. I am absolutely confused, and I've been doing this for years. So I was left with this thing, do I kind of show you all this data, which is confusing? Do I show you all the studies, which is just as confusing, or do I just talk you through what we do? Okay, what we're trying to do across the country with COVID and pulmonary emboli. Now, I don't care about questions. If questions come through, stop me. I can answer them at any time, and I'll probably ask you some questions as well. So I know there's no audience in front of me. I'm a bit different than most people. I'm itchy. I always have itchy feet. I was lucky as a medical student. I did some time in America. Then as a junior doctor, I went out to Australia, worked for a few years. And at the top, this is the MRI where I work. At the bottom, you can see a little picture. That's me. That's John Bright, which is great. It means if you ever Google me, you find this famous politician, which is absolutely nothing to do with me, but it keeps me under the radar. But at the top, the MRI, but the one in the middle is where I've been for the past 2 years. So I left the MRI. Even though my clinics continued, which is odd, but I left the MRI and I worked out in the United Arab Emirates. And this is a small hospital in a place called Ajman. And I was the head of department of medicine, chief medical officer, whatever you wanted to call there. But I was also a professor of medicine at Sharjah University. Now, I came back for COVID. Okay, it was untenable to live there. So I came back March of last year, and that's all I've done. I just do COVID. Okay. Fine, and I can take you a little bit through my experience. Now, you got the slide in front of you. When it comes to clots and COVID, and I know we're talking about pulmonary emboli, just stick to the basics, okay? I hope to God everyone knows who this man is, okay? And I don't care if you say Virchow, Virchows, but this is the father of thrombosis, and his birthday happens to be the 13th of October, which happens to be World Thrombosis Day. Everything we talk about comes back to this triangle in front of you, okay? And it's all related to that. And go back to the basics. And we know his triangle: endothelial injury, circulatory stasis, hypercoagulable state. I might as well just imprint all over this COVID. I might as well just write COVID all over this. Because COVID is slightly different. You have an endothelial bed injury. You have an endotheliitis. You've got a hypercoagulable state, and you're immobile, circulatory stasis. So go back to basics when you're thinking about it. And you get to be a heretic. I've spent my life talking about pulmonary thrombosis, and then people will laugh at me and go, what are you talking about? It's all emboli. No. It has always been pulmonary thrombosis.
John, we're still stuck on your first slide. Sorry, darling.
Is it not moved?
No.
Oh my God. Right, let's go reshare the screen. Because mine's moving. Can you see it at all?
Just your very first slide.
All right, I'll turn this off and resume share. Is this moving?
Yay!
Yeah, let's see if it moves first. Yeah, moving or not?
No.
Oh, all right. I might have to stop and start each time. Good old NHS computers. Right. At the moment, which slide can you see?
Your Virchow's triad.
Right, we're stuck on Virchow's triad. Okay. This is going to be laborious for you, but I'll move through this way. Okay. All right. Can you see this way? So you've got Virchow's triad, which you must do for everything. And in front of you now, you've got something new, which is time to be a heretic. And we're talking about pulmonary thrombosis. And as I said, for my life, I've been called a heretic. We have always known that inside the lungs, you get an area of pneumonia, and there's a blood vessel going through the area of pneumonia, and there's a blood clot in it. And we've been calling it an emboli because we just always call it an emboli. It was always a thrombus, but we never spoke about it. Now we have to, because we're talking about a thrombotic disorder inside the lungs and an embolic disorder coming from the legs, all at the same time. So remember, COVID clots in lungs are emboli, and small clots, microthrombi clots, but also immunoclots. Can you see the next slide? Has it changed?
No.
There we go again. Okay. This slide is all about remember you're a clinician. Okay. COVID is about clinical medicine. It was about a lot of us were going back and doing what we've done before. Hasn't moved? Well, you can see it.
Haven't got anything, John. Sorry.
Ryan, you may just be getting a nice talk because these slides are not showing. Okay, so what in front of you, you've got these famous physicians, and we're talking about the famous physicians who came up with blood clots. And we start off with a guy called Morgani, who was an anatomist, and there's a guy called René Laennec. René Laennec invented the stethoscope. And then the stethoscope, okay, was basically two ear trumpets put together with some rubber tubing. And there was this poor guy called Jean Crevilliers. And Jean Crevilliers actually invented Trousseau's disease, which is superficial phlebitis related to adenocarcinoma inside the bowels. But he died of his own disease. He actually developed his own disease. So they renamed it Trousseau. But these are famous clinicians. And we needed to go back to be a clinician in COVID because we ended up being statisticians and we were forgetting how to manage people. All right. Don't worry too much about that slide. I'll move on. Has that one come up? Still a no. Okay. So for this slide in front of you, what we're talking about with blood clots is we have to go back to the basics. And in front of you, you would have seen a slide, and it talks about predisposing factors for clots and risk factors for clots. And again, if you could see it, you'd be able to superimpose COVID. So when you start thinking of predisposing risk factors for blood clots, you think of someone who's obese, you think of someone who's immobile, you think of someone who's got chronic disease processes, renal disease. That's exactly the group that the COVID virus took out first. And I'll say that took out first because each wave has had a different demographics, but that's the people who get clots. And then the acute precipitating factors for clots, we have always known acute medical illness, acute respiratory failure, central venous catheters. So we've got this perfect storm of somebody that hits all three parts of the Virchow triad, but has the correct predisposing factors. It's almost as if the virus looked for the person in the community who is more likely to get blood clots. I'll try and get this slide to actually work because it's important. Can you see this one? Still a no? Give me 1 second. How about that? Has that worked?
No.
Nope. Okay. This is going to be a great one for you all today. So in front of you would have been the Da Vinci's man. So in your brain, think of Da Vinci's man, and you can see me on the camera. It's the guy that puts his arms out like this. And you have to remember clot medicine. Okay. Now, we talk about different parts of the bodies, and we talk about the lungs being the soul. That was the idea of the soul in ancient times. But actually, the lungs are two whopping great clots, and they're there to filter the blood to make sure that small blood clots don't go up to the brain and cause a stroke. Okay. Now, think of the further away they are from the body, we don't care about. So proximal clots, distal clots, we do not care about. As you get closer into the body, we get more and more interested. So if you have a proximal DVT, we are interested. If you have a central blood clot, we are interested. Now remember, clotting is actually a way of encapsulating bacteria so we don't become infected. So when it stops blood, there's hemostasis, but it also stops infection. It grabs hold of all these bugs and it stops things progressing. So clotting is actually a natural phenomenon. And then I go to the next bit, and I usually ask people, in France, what do young men do in the evenings in Paris? So the question will be, you don't need to put this in the chat because you'll put something rude, but what do young men do in Paris in the evenings? And the answer is, they drive their scooters at speed and fall off them, and they don't wear helmets. Okay, so what they did in French, they looked at the dead bodies, 10 young Frenchmen, didn't tell the pathologist, because he was blinded at this stage, what they died of, and asked them the cause of death. And these perfectly normal people, 30% of them died of blood clots, which is impossible. They died of head injuries. They also kind of did these studies as well with Americans in Vietnam. They were finding people who had been shot, head injuries, shot, but finding what they thought were significant blood clots on the inside. So the idea that the lungs are there to filter, and there's a difference between a small subsegmental blood clot and something which is large, okay? And that's kind of important when you've got a new pathology of immuno-induced thrombosis. Now, the next slide, which you can't see, is coronavirus. Does anyone know where coronavirus came from? And you can put this in the chat, which gives me time to get these slides working again. Well, coronavirus, there's a timeline in front of you now. We don't really know what happened, okay? As I mentioned, I was working in the Middle East in the latter end of 2019. And at the last 2 weeks of November, we had 2 patients who came in, and they were overseas workers. They hadn't come, they didn't think they'd come from China. Both were young men, both had a mysterious virus, both had what we thought was alveolitis inside the lungs, both went on to ECMO and passed away. And there was an alert from the UAE government, that is Emirates, the Dubai government, okay, that there was a MERS outbreak at the time. We actually thought there was a coronavirus MERS outbreak. And this is November. So we shouldn't have been seeing these patients. So what you'll see as the dust settles, we're going to shift the timeline across. So this virus was outside of China in December and probably November 2019. And then what really happened, we're never really going to find out, but it is a natural virus. It's definitely not 5G, and it has nothing to do with the CIA or anything. So Bill Gates. So I don't know if anyone knows the Bill Gates story. So allegedly Bill Gates patented the virus, but he also patented a couple of hundred of viruses, because that's what rich people do. They take the patent on viruses in case they become useful in the future. Without the slide, this will be challenging for your mind's eye, but inside your mind, okay, just think of the virus, and then I'm going to translate the virus now into a grumpy old man with a pair of glasses, okay? He knocks on your door and he lets himself through the key, because he can see what we call the ACE2 receptor, and he lets himself into your house. You're not there, okay? And basically comes into your house and he unfolds a suitcase, and inside the suitcase is a photocopier. Okay, and what he does, he steals the family silver from inside your house, which is actually the base pairs to make virus. And he steals these things. Think of things, something called adenosine. He steals the silver and he puts it into his photocopier. Just imagine at the other end, a paper chain comes out, a single chain of paper from the photocopier, and he's replicated himself as virus. And he does this over and over again, stealing all of these things from inside the cell. And at the end of it, he suddenly becomes Superman. But he's not Superman, he's some kind of 1970s rock band, and he absolutely smashes the place up. So he's come in, he stole all your silver, replicated himself into a base chain, paper chain, and then smashed the place up as he leaves. Okay, and that's what the virus does. It comes in, it takes over the cell, but as it leaves, it smashes the place up and you get an inflammatory response. Okay, and that's where we get in this immunomodulation, the immunoresponse for the virus. And we talk about the different waves. I don't know, is this audience all Manchester based, or are you from all over the world, or all over the UK?
We're all over the UK.
So Manchester's had 3 waves. Okay, we had 3 waves of coronavirus up here. We had wave 1, which was an old person's disease. It was an old person's disease. 60, 70, 80 were really the people who were coming into hospital. And we had quite an intense time for basically April, a little bit of May, and it went away. And we had very little virus circulating in the community. Took us through to the 2nd week of August when wave 2 started in Manchester. Slightly older disease, around the 60 mark, but slightly older. Our wave 2 took us from September to November. We cleared again. We cleared all our patients out. And then we had the Kent variant came up. And it wasn't realistically the Kent variant, it was just the way that we were going back to our lives. And the disease changed to a 20 to 40-year-old disease. That was the age of our patients. You can imagine the types of clots we were seeing were changing with the types of patients that we were seeing. Now, you have to remember, for this virus, you've got three phases, okay? And you start off, at the beginning, you have an intense viremic phase. This is when people go to bed. So they're at home and they go sleepy, they go tired, they go to sleep, okay? And they're immobile. And I had patients who were asleep 20 hours a day, not eating, not drinking. Virchow's triad, immediately, immobility. Next thing, there's an inflammatory response inside the lungs. We see the ground glass, and it's an inflammatory response inside the lungs. Inflammation, Virchow's triad. And then you go into the hyperimmune, and it's this combination of the inflammation and the immune response results in endotheliitis. Now, you can hopefully you can actually see me on the camera, because I'm trying to make it a little bit interesting with that slides. And if you look at my eyes, we've always said, as doctors, you can look into the soul of a human being through their eyes. What we were really saying is I can look at your diabetic retinopathy. But what we found is by looking into the retina, we can see the vascular bed. This is very, very early days, and this is specific to Manchester. But one of the professors in the ophthalmology department has developed a computer program. We can look into the back of your eyes just with a photo, and we can see the amount of damage to capillary bed. We can see the amount of capillary damage, hence the amount of organ dysfunction you would have had inside your body. And we're seeing stark results. Some of the patients who've had COVID, not gone to the intensive care unit, but had the viremic phase and then the lung phase with organ damage, they've got retinopathy, the equivalent of 30 years of diabetes. So it's quite marked, the changes we can see. It's the whole idea that it's a pro-inflammatory vascular bed disease. I was going to show you a load of chest x-rays next about lungs and COVID. And it was just to try and show you how difficult it is to tease out blood clots by looking at radiology and looking at CT scans, and just trying to explain a little bit of how we went through the management. But when you look at, in your mind's eye now, you'll have to start thinking of blood clots, chest x-rays and people breathing. Because people were so tired and lethargic and asleep, everybody came into hospital, their lung fields were squashed. People were breathing at end expiration, either breathing all the way out. They're so tired, they can't take a deep breath. All of the x-rays were like that. And if you're interested, the virus loves the back of the lungs, where 60% of gas exchange happens. And that's where the virus was stuck. So you had small little lungs. They were compliant. You could take a deep breath, but the patient couldn't because they were so tired. And it was peripheral disease at the back of the lungs, all inflammatory. And if you saw the CT scans, you'd realize how difficult it was for us to say, what is a blood clot? Because small subsegmental blood clots are virtually impossible to see. Segmental are virtually impossible to see in some cases. However, the large obstructive ones, which we're really interested in, are visible. And it was going to talk about the ideas that as we went through the different waves, we had limitation of resources, which I'll come back to, about how we treated. Right. Any questions so far?
Yeah, there is. There is one concerning PE risk and COVID vaccine. What's the main difference between the Pfizer and AstraZeneca vaccines?
So obviously this is a COVID and PE talk, but I knew I'd get a VITS question. So vaccine-induced thrombocytopenia. So vaccine-induced thrombocytopenia. So you've got the different vaccines, and it's viral vaccine-induced VITS. And yes, I have seen VITS now. I have seen people coming into hospital with the thrombosis inside here. The vaccine which you have from Pfizer, okay, is, they talk about an intelligent virus or an intelligent vaccine. And basically what they've got is a fat ball on the outside, and on the inside they've got the spike protein. Okay, they inject into your arm this fat ball, and it just gradually reduces, and inside this spike protein is there, but it's still got the grumpy old man with his photocopier, and he makes this spike protein. Now the spike protein doesn't damage you. The spike protein doesn't smash the place up when it leaves. It just turns your arm into a factory. Little old man with a photocopier making this spike protein, so you make an immune response. Now the viral vector vaccine, and it's something to do with imagine you've got a virus, the normal virus, and they've superimposed the spike protein on it. Somewhere along the code of this vaccine, it looks like it's going to induce an antibody the same as HITs, okay, heparin induced. So the body, you replicate the spike protein and the viral vector that they've put in, and the body misreads it as an antibody, okay? And the antibody cross-reacts with platelets and causes VITS. Obviously, it's not heparin induced, but low platelets and clot. Hopefully that answers, because we don't really know that much about VITS at the moment, okay? But it's a cross-reaction. So one is basically using the grumpy old man to come along and make the spike protein without killing the cell. This one is fooling the body into replicating something, and it's accidentally causing an antibody towards platelets, which causes a coagulation cascade. And to make it easy, previously for sagittal venous or thrombosis inside the brain, you had to have a headache and focal neurology. Forget about that now. You don't have to have the focal neurology. So it's the equivalent of a tension or a pressure headache. Inside the blood clot causes lack of drainage of the venous fluid, and it's an all-encompassing headache. So it's basically they're coming in like this, ow, and it's slightly different to previous sagittal venous thrombosis, where it's more focal headache with focal neurology. Any other questions?
There's nothing coming through on the chat at the moment.
Okay, so the next one, I'll see if I've given it a chance. I doubt this will work again, but I will try. Definition of madness is to try the same thing over and over again and see if it works. And I'm assuming it didn't work, and you can see the slides. Basically, with the slides, We don't know realistically a lot at the moment. There's lots of studies, there's lots of people publishing, and we've had the Twitterati and people publishing what they want to become famous. So we've ended up with good information and bad information all at the same time. And in front of you is just a quick slide just talking about when somebody comes into hospital, what is their rate of having a blood clot compared to somebody who comes into hospital without COVID, and make it really, really easy. And then I'll give you the explanation. If you come into hospital and you have COVID, you have a rate from 0 to 80% chance of developing a blood clot during your admission. Okay, compared to somebody else who doesn't have COVID, who only has a 7%. And you're going, those are wild figures. Those are wild figures, but there's a consensus. Yes, COVID is a risk factor for having a blood clot. Now, remember, the COVID loves the patients who have got them anyway. Yeah, so it's picked out, if you are susceptible for a clot, this virus loved you and then brought you into hospital. Okay, and made you unwell and made you immobile and caused an immune response. So yes, there's an increased number of clots within this patient group. Now, one of the theories is that they would have had a clot anyway at some time in their life because they were predisposed, because we've had such a prevalent disease, they've all just come at once. Okay, so yes, we've seen lots and lots of blood clots.
So there's one question just on the chat there now about COVID associated VTE, and how long would you treat it for?
Yeah, well, so this, the next slide is exactly coming into that. So you've got this idea here in front of you. So just quickly, this is prophylaxis is the key. So prophylaxis is the key to start with. Yeah. And they did a study and they basically said people who had prophylaxis versus people who didn't have prophylaxis, how many people died basically. And there's about a 5% improvement in mortality if you have prophylaxis. Okay, don't worry about that. Now, the question you asked was about how long to treat. This is where it gets really complicated, and we've changed so many times over the pandemic. And the latest iteration is not favorably received by clinicians. I won't go into all of it. I'll just quickly go into the question. The question is, how long after a proven VTE event would you treat? That's easy. Okay, so you start with your Da Vinci man. Okay, if the blood clot nearly killed you, you will treat it like a blood clot that nearly killed you previously with lifelong anticoagulation. Okay, so you start with that one. You're still a clinician. If you've had a major thrombus that nearly killed you, okay, even though this is a provoked event secondary to COVID, it is definitely a provoked event, but if it nearly killed you, we would give you lifelong anticoagulation. And we've done that for a very long time. So if you have a massive PE secondary to having an infection, we would still give you lifelong anticoagulation. Okay, so you start off with that. But because it is a massive provoking factor and you've got all the three sides of the triangle affected, 3 months. So small blood clot in the legs, was it symptomatic or not symptomatic? It doesn't matter, it's 3 months and stop. Segmental, subsegmental pulmonary emboli, 3 months, then stop. Then you go into these equipoise people, but actually the equipoise is to stop. Then you go to the people that would be offered lifelong anticoagulation anyway, then you continue on. I think the easiest way is to field questions because you can't see the slides and a lot of the answers are on the slides.
Mm-hmm.
So has anyone been confused by the D-dimer? The D-dimer caused an absolute disaster for us. And one of the slides is to say you're a clinician, not a statistician. And when the virus came up, we got lots of doctors from all these different specialties. I'm an acute physician, I'm a respiratory physician, and I deal with blood clots. I'm very, very pragmatic. D-dimer, as I said, I know that the clotting cascade was there to grab hold of these bacteria to make sure we didn't die. Okay, one of the ancient responses inside our bodies. So when you become unwell, your D-dimer goes up, because not because you've got blood clots, because you're fighting off an infection. So D-dimer for me has always been a marker of severity of disease. So for me, a D-dimer being raised does not equal a blood clot. And the whole point is, as a clinician, if one day I come into hospital and I'm treating a horse, fine, I'm treating a horse. The next day I might come into hospital and it's changed and it's a racehorse, still a horse. Next day it's a mule. Well, it's still a four-legged creature. Next day it's a zebra. It's still the same creature. It is still COVID. I don't change my way of treating people each day because it looks slightly different. If I walk into the hospital one day and the horse has been replaced by a fish, there's something wrong. So it's the idea that people couldn't diagnose blood clots. Of course they're breathless, they've got COVID. Of course they've got chest pain, they've got COVID. Of course they've got hemoptysis, they've got COVID. But giving them full dose anticoagulation was probably the wrong thing to do, and definitely the wrong thing to do in ICU. Okay. But if they suddenly change and they're a completely different animal, and I do a whole talk about the WTF sign. The WTF sign is exactly what it says on the tin. Okay, it's to make you stop. WTF. And this is for people, a normal human being, if they become suddenly breathless, they're walking, they're talking, and they're falling, they've had a blood clot. Very little else that can do that to a human being. These people came in really sick anyway. They would never be walking around and talking to me, and they may collapse anyway because of the severe COVID. So you have to use other things. Is there been a sudden deterioration? Has there been a deterioration in oxygenation? Has there been a deterioration in the cardiovascular status? And then became the importance of ultrasound. Ultrasound previously could show blood clots in the lungs, okay? Not with COVID because it looks the same. But you would look at the heart. I would actually look for signs of right ventricular strain, not in ventilated patients, but on the ward. And I could actually start risk stratifying who needed to have a CT scan, who needed to go on to treatment. And we went for a whole different kind of paradigms because we also had the risk of bleeding. And we did at wave 2 have lots of people anticoagulated, but we also had quite a lot of bleeds. Okay, I'll leave it there on explanations because of time. And I really apologize. You can blame Zoom for this because it moves one and then stops and moves. Well, you can blame the MRI for their technology, but usually its technology is quite good here. Questions, okay?
So Joseph would like to ask about pulmonary hypertension and being a complication of PE. What's the main guideline for management in this instance, and is it covered by long COVID clinics?
Well, long COVID and all of these things people get mixed up. I'll answer the question and I'll explain about long COVID because people don't understand what it is and it gets thrown around as if it's a thing. And it's not, it's 3 separate entities. Pulmonary hypertension post-PE. So when you have a large blood clot, you have an obstruction and you have dilatation on the right-hand side. So pulmonary hypertension, we still treat exactly the same thing because within the PE groups, you've got subsegmental immunomodulated clots. I'm just going to give you 3 months worth of treatment. Maybe segmental, related to the inflammation inside the lungs. 3 months. These are pulmonary thrombosis, but these whopping great things, okay, they still came from the lower limbs. These are still significant blood clots, pulmonary emboli. So that's the group I'm looking for, the pulmonary hypertension. Now, I don't do anything at the beginning. I wait 3 months and I do an echocardiogram. If you still got high pressures, again, I don't really do much. I kind of go, oh, you got high pressures. I'm a bit worried about you. I may need to do something exotic, but I probably won't. But between the 3 and 6 months time, most patients kind of declare themselves. And if they've got persistent, significant cardiorespiratory dysfunction, i.e. they're still walking, but they're talking and falling over, syncopizing, or evidence of cor pulmonale with peripheral edema, I'm sending them on to Sheffield. Sheffield, okay, we do transthoracic. Sheffield will do a right heart catheter. Sheffield is the pulmonary hypertension centre for Manchester. Okay, and then there would be candidates for oral tablets, intravenous agents, or more importantly, embolectomies. So far, my kind of take on it is that every 2 years, I would find one patient to go through thrombectomy. That was the kind of the figures. I would assume, because I've seen larger P burden through COVID, I would have picked up somebody that required thrombectomy. So far, no, but that's not a study. That's just anecdotal medicine. Now, long COVID. What is long COVID? So you hear lots of different people say lots of different things. You've got three separate groups. You have a group of people that come into hospital who go to the intensive care unit. So they have post-COVID organ damage, but they have post-damage to systems from being from the intensive care unit. That's not long COVID, that's organ damage secondary to ICU and the viral pathogen. Next group of people come into hospital. Again, they have organ damage, be it lung, brain, heart, kidneys. These two groups will take between 3 and 6 months to get better. This is organ damage. Now, post-COVID syndrome never came into hospital. Sometimes never even had a positive swab. Never had organ damage. This is the most unfortunate group, because what we're finding is they've still got small vessel damage. Group 1 and 2 clear the virus, they get better. Okay, they may have some structural damage, which is quite rare actually. These poor people with post-COVID syndrome, they never clear the virus. The virus, it's not that the virus was replicated, but they never clear the effects. And they've got small vessel damage, hence the idea of looking in people's eyes. And if people are interested, it's the autonomic dysfunction. It's the idea that, imagine nerves, blood vessels, nerves, that's what's damaged. Your heart does weird and wonderful things. Your blood pressure does weird and wonderful things. Your brain doesn't work the way it did before because there's small vessel damage, and I mean capillary bed damage to nerves, to brain. And this is the group which is the most unfortunate, okay, because getting them better is challenging. And yes, we do have things, okay, we do have things, but that's a different discussion.
So Thamis would like to know if there's been any COVID patients hospitalised presenting with clots, even though they were already on anticoagulants.
Yes, but that's the same as anybody. So I've had, throughout my career, I've always had people who've had a blood clot and they've not responded to normal treatment, and I can keep going. I can name and you go through warfarin, it's not working, then you extend the warfarin, you've got higher doses, then you add in a low molecular weight heparin, then you're on fundoparanox. So for some people, and these are the ones who usually end up with endarterectomies, so they're on the blood thinner, whatever, COVID is the precipitating factor, done. Then they've got the clot, but the clot itself grows. So the clot is now the thrombogenic. And I've literally looked after people, and it started as a segmental clot, or what I thought was a segmental clot. And over the time that I'm following them up, it grows closer down in towards the heart because the clot itself is so thrombogenic. It doesn't make any difference if it's warfarin, fundoparanox, low molecular weight heparin, whatever. And the only way to treat them is to remove the clot, which is surgical intervention. But yes, unfortunately, I have.
So in those patients then as well, would you change their anticoagulant or would you keep them on the same?
Well, it depends what they're on, isn't it? So this is more for the hematology guys. Okay, so these are the ones. I'm a respiratory physician. So we'd start off on warfarin, then we'd fail on warfarin. Then we go on to low molecular weight heparin, and they'd still get worse. Then we go on to double dosing low molecular weight heparin with factor 10A levels. Then we go on to fundoparanox. Okay, so that's kind of the way that you jump through them. Yeah. Now, NOACs, previously we didn't use them in large PEs. I'll be honest, we didn't. But they are coming in a little bit more because of ease of use. Yep. Previously, you asked me 3 years ago, would you ever use a NOAC for someone who had a life-threatening PE? And I go, not for the first 6 months. I want them on warfarin. So, but now things have changed. So yes, you could add in a NOAC at some stage. But the reality is, as doctors or as healthcare professionals, we like to give jabs. So you're going to end up on low molecular heparin or fundoparanox at the end of this.
Okay, one just coming through now. So Joseph again is asking, if you've had COVID previously, would you consider that as a risk or a predisposing factor to developing blood clots in the future?
Well, it's an isolated event, and this is really important with COVID. And again, there is no study here. This is experiential medicine, and I'll explain. So you have COVID, it's an isolated event. You have your clot at that point of time, or 1 or 2 weeks later. You go on a plane, fly around the world and get whatever you want to call it, DVT, economy class syndrome. We all know from taking history, the economy class syndrome, you start with a blood clot, the size of a pinhead here. Now, that clot has to grow to a point to being clinically significant to cause symptoms, which can take up to 8, even 12 weeks. Because when we take a history for clots, we go back 8 weeks, 12 weeks, what are your predisposing factors? So with that logic, somebody coming into hospital with COVID, I should still be seeing their clotting events maybe 3 months down the line, and I'm not. And I'm going, I just don't understand that. That really, I don't understand. Obviously, it's a different disease process and it's hitting different parts. But in my experience, if you have a clot, it's an isolated it's an isolating provoked event. It's the akin to having your leg broken and going into a plaster of Paris. It is that type of thing. But it doesn't appear to have this risk 3 months down the line. I'm not going back and saying, oh, you were here with COVID in a mobile 3 months ago, but now you've got this massive PE. I'm not seeing that. Even the small ones, I'm just not seeing it. So just think one, and the clot develops quickly, grows quickly, embolizes quickly.
Okay, there's nothing else coming through now.
And I have to thank you, Joseph, because you've rescued my talk by asking me questions. Thank you.
So thank you. Despite technology issues, it's been a really informative and very, very helpful talk this afternoon. And thank you to everybody as well attending for your patience. The slides will be available on the Thrombosis UK website. So if there was anything that you wanted particularly to talk about, drop us an email and we can forward to John maybe.
Yeah, I'm very, very, very happy. And I just apologize for the slides. Some of them were quite funny as well. I was proud of some of my slides.
Lots of love coming through for you, John, on the chat. Thanking you for a great session.
Yeah. And as I said, don't forget the WTF and the whole thing about this, all of this COVID, we turned into people just looking at numbers and forgetting to be clinicians. And there's this thing that you always ask your patients what's wrong with them. And in COVID, we weren't allowed because we tried to stop patient contact. You have to, patient contact, listen to your patients. Yeah. Thank you very much.
Thank you, everybody. And again, for your CPD credits, the videos will all be on the Thrombosis UK website until the end of May. So if you've not had opportunity, or if there's any other sessions that you want to get involved in, you've got until the end of May to get your credits. Have a great weekend, everybody. Thank you all very, very much for your time today, especially you, John. You take care.
Thank you. Bye.
Bye.